Good morning. Thanks again. My name is Eric Finkelstein, and I'm from Tel Aviv Medical Center. And I was asked to give a short talk about my way or our way, our odyssey in the last 20 years with the TAVR. So I'm going to say a few words about the history of TAVR evolution, our frustration in the beginning, what have we learned, and finally what I have learned from this journey. Now, regarding the history, you have shown this picture of Anderson, who did the first step, but as a matter of fact, the real deal was done by this wonderful person, Alain Cribier, with Martin Leon and Helen Elchaninov 22 years ago. Now, they did this case in a retrograde manner, and this is the first case, and this is what it looked like by the end of the procedure. Almost in parallel, but a little bit later, Jean-Claude Lebaudet with Eberhard did their first case with the self-expandable valve. And then we were introduced with the first generation of the core valve that was non-retrievable those days, and Sapien, and then the Sapien XT. We have learned the aortic valve, which is really, really much simpler and stupider than the mitral one, with just a fibrous core and endothelial lining. We have learned and invented, as a matter of fact, those three rings that are not true anatomical rings. And we learned from that time in the beginning, whereas the AV node that we have to be aware of, and the distance to the corner is that according to the PM, CT, and angio, were longer in the right corner than in the left. And then we started with our frustrations. We're frustrated because it was what we call the unfair play of TAVR, that as opposed to PCI, that every fellow starts with the simpler case of discrete, accessible, non-calcified type A lesion, we started with the very, very high-risk patient, very challenging and very difficult clinically and anatomically. They were very old with LV dysfunction, comorbidities, and renal failure, etc., but as compared to those metastatic carcinoma of breast, lung, colorectal, prostate, and ovarian, this was the prognosis of the patient that we started with. So they were very old and very frail and very sick, but they wanted to live. So we had those first early hurdles with the mortality, the stroke, the aortic rupture, the occlusion, embolization, the PVL, etc. You all know it. And most were significantly reduced a long time. We started with the huge numbers of mortality, as Roxana said yesterday. We're not used to it. I mean, we're dealing with coronaries, and you rarely see a patient who is dying in a procedure unless he comes with a shock or acute MI. And here we started with almost 2 digits of mortality. We're frustrated because we had around 10% of severe or vascular complications that increased mortality. But the main problem was the calcium. You see those two bones here. Do you see that? Oh. Those two bones are the valve. And just have a look. You see, this is the balloon, and this is this bone, and we just move it to the side. And you see it's here. We don't really break it. And when we inflate the valve, and this is the Sapien, the first generation, you see it's here, and we just move it like a door to the side. And it is still there. Nothing happens to it. So sometimes it's still there, we're lucky and have a nice result. But sometimes it's here, we're not that lucky. So we wanted it to look like this. But it's not like this because it is still there, and we hold those windows to have the PVL. And PVL was again, a 2-digit number and increased mortality as well. So what have we learned? Well, you know that we learned from randomized controlled trials, from registry, and from small observational studies. And we had the partner one, and you know, and I'm not going to go over it, but what you know, and it was published in the New England, we know that there was no inferiority to surgery, but as opposed to medical therapy, for which the vast majority of those patients were entitled to, there was a reduction, an absolute reduction of around 24%. And if you want to understand what does it mean, the absolute reduction of aspirin, fibrinolytic, beta blockers, ACE inhibitors is those numbers. And here there was a no option patient with a 24%. And then we had all the other partners, and I'm not going to go through it until the low risk one. And then we changed the generation of the valves, and we got better and better results, and everything went down. The mortality went down, the stroke went down, the moderate or severe PVL went down to now, those days, almost 0%. The devices became smaller and better, and we had the protection, cerebral protection devices, and then we learned about the heart, and then we start talking about the durability, and we had the VARC 1, 2, and 3 definition. And the notion showed us that we are not really inferior to the surgical valve by the durability. And then we learned about doing this with bicuspid valve, and Ewan and Raj Makar showed us which patient should we do and which one we should not do with the calcification. And Ran Kornowski, my friend, and Danny Dvir, that was supposed to be here, he was those days a fellow in Tel Aviv, and they published the first registry of valve in valve. And later on, Uri Landis was a fellow at the same center, did it with John Webb, with TAVR in TAVR. It's not working? Oh. And then we have even cases of TAVR in TAVR in TAVR. We had the coronary access difficulties, and then we started to do a TAVR in the mitral until we'll have the next generation of mitral valve bioprosthetic for implantation transcatheter. And we had patients like this as well. And Roxana talked yesterday about the adjunctive pharmacotherapy that we learned more and more and more. And we did the minimalistic approach that Ioannis wanted to show us yesterday. We started like this. And this is what I look in my cath lab those days. I'm pretty much alone. Somebody is joining me just for the implantation. I have one nurse and one technician. But what I have learned of this journey, well, I've shown you yesterday, those are the guidelines, the European ones, and those are the Americans. But those are the numbers. It's pretty sad. Those are the numbers in spite of the guidelines. And the numbers are because this is what a 75 years old patient looks 24 hours after surgical AVR. And this is what Mr. Cohen, who is 85 years old, looks 12 hours after TAVR. So we say in Hebrew that the patient are voting with their legs. And Michael Mack said once that when two procedures are equal, the less invasive procedure wins. It should not be like this all the time. It should be like this only if it's correct. And I'm telling you this because, you know, this is a paper in the New England comparing lap cholecystectomy to open cholecystectomy, okay? Do you know this paper? No, you don't. You know why? Because there's never been a paper like this. There's never been a study like this. It's a fake. I just created it. It's because the same people are doing lap and open at the same hospital. So they don't have to prove themselves which one is better. And I'm saying this because, look, when the TAVR started, you know, the Gillette stock market, you know, the shaving knives, they dropped by 92%. And this was just because this man, you know him, right, Clooney? And a few weeks later, the soccer Beckham player, okay, they didn't shave. And all the rest is history, okay? My 4 sons-in-law and my son, they're not shaving, they're just like this. And I'm showing you this because we are in an era that many things cannot be anticipated, but many can. And Charles Darwin said that it is not the strongest of the species that survive, not the most intelligent, but rather the one that is most responsive to changes. And when I'm talking about changes, you know, that's what I did in my hospital. I took my chief of surgery and convinced him to join me and to do TAVR cases with me. And I said, like Confucius said, you know, a long journey starts with one step. And this is Udi Ra'anani. Muni knows him. He is the leader of cardiac surgery in Israel. And I love this picture because we're here in Toscana. I'm sorry. We're here in Toscana. We're laughing. We're debating a lot about this. And we're sitting in a chair that each one of us is in a wrong direction, but we're still friends and we're laughing. And this, in spite of this, have a look. This is the TAVR. And this is the surgeon. He's not that poor. Have a look. This is me. Now, regarding the future of valvular disease, we need to work with the surgeon to define where we go next. Neither TAVR nor surgery will look the same in 10 years, and we're at a critical time in terms of defining the future treatment of valvular and structural intervention therapy. Now, I had the privilege to witness the TAVR evolution over the last 20 years, to study the field, to learn the technique from pioneers and top experts, and to teach others. I had the privilege to help aortic stenosis patients in need, to explore research, to contribute a bit, and to look for the future with great enthusiasm. I'm sorry. I feel fortunate to be part of this exciting medical journey, and I strongly recommend the young generation of cardiologists to get on board at the various treatment tremendously important specialties of structural valvular disease, diagnosis, and intervention. I truly do think so. Thank you so much for your attention.
Thank you very much, Professor Finkelstein. I mean, you made this journey, a really fascinating journey, so educational and so nicely presented. Can I talk about expanding the criteria, expanding the indications in moderate aortic stenosis? I mean, I can understand in moderate aortic stenosis that we need criteria like imaging criteria, GLS or interstitial fibrosis, but do we really need criteria in patients with moderate aortic stenosis and heart failure in a double-loaded ventricle to get rid of the afterload? You understand what I mean?
I think it's a wonderful question. It's one of the most important questions those days that we are facing. Now, you know, it always gives me a déjà vu of the stent era. Now, you all remember that none of us would have sent a patient with just a proximal circumflex stenosis to surgery. But at the same time, and I'm talking about the time that I became interventional cardiology, we had no stents, okay? And part of the patient were inflating a balloon and then standing for 20 minutes with inflated the balloon, which was reperfusion balloon, you know, with a hole inside, in order to, anyhow, to take care of this dissection. Now, why am I saying this? Because unlike surgery, you know, you can say, look, the patient has got moderate aortic stenosis, but he has LV dysfunction. Why won't I do TAVR? Because it's not opening the chest, it's a 40 minutes procedure, etc. You're absolutely right. But unlike the stents today, there is one black side, the durability. So any patient that is coming to me and I see that he has aortic stenosis, but he is not symptomatic, for instance, or is mildly symptomatic and he's got no, I'm trying to postpone it according to his life expectancy as compared to the durability of the valve, because this is a critical part of the decision making, not like many things that we did before. Otherwise, I got no doubt that somebody with moderate aortic stenosis and reduced LV function, TAVR will help him. The only question is if it's right to do it early or not. But whether it's going to help him, no doubt about it.
Yeah. So on the same note, so we were talking about lifetime management, and we discussed yesterday as well, and Roxana had this argument that maybe it's too much for a 65 years old and a younger patient to proceed to TAVI, but still you see that the TVT registry data, and you have 50% of these people, these patients undergoing TAVI. But yes, maybe it's too much, but maybe, you know, it's their decision, and they can do it.
Yeah.
So it's patient decision as well, and if someone wants
that's
to
the point,
do
Ioannis. It's not always the patient decision.
Yes.
This is wrong. You know, I think that the patient in the center is right until a certain note. You know, because the patient will tell you, I don't want surgery. I mean, you can understand him, but your duty is to convince him and to recommend what is better for him.
But if you, let's say that you have a patient, 60 years old, you know, healthy, but suitable for transfemoral and approach and has tricuspid valve, and he wants to say, you know, you have and you propose to him to place an annular valve, and maybe after 8 or 10 years you have a supraannular valve. Why is it bad? So it's the life expectancy is 80 years or more. Yeah, why
because if nothing changes, it won't be enough. Because within another 10 years, he's going to need a third valve. Now, you can be the devil's advocate and says, Eric, come on, we both know that within 10 years, there's going to be a resilia that will last for 30 years. And I'll tell you that you cannot treat patients according to future technologies. So, you know, it's endless. It's really an endless discussion. But I think that right now, it's really incorrect to take a 60-year-old patient, unless you have a good reason for this, and do TAVR on him.
Good. Any other comments?
Just to clarify also, there's a lot of discussion made about this 50%. First of all, it's a percent. Not that many people exist in that bracket, all right?
In what?
In the 50% of under 65 in the United States, TVT, first of all, that bracket is very low. There are not that many people getting valve surgeries. And I can tell you the TVT registry doesn't capture many things, rare things, lymphoma, myelodysplastic syndromes, this, that, the other. And many of these people have one of those rare conditions, any one. So it's not like fantasizing the normal disease-free 55-year-old walking in and having a TAVI. I don't think that at all. It's just that it has things the registry doesn't capture. Each one of those things is rare, but any one of them exists more frequently than we think. And that's what it's, of course, a few of them that, I don't know, maybe they don't want to take time off their work, this and that, who knows, maybe they think they're smarter than the data. This is a small minority. Most of the people, they have a reason, some reason. Now you tell me, is it significant, is it, no, maybe not 100%, but there's some indication that is weird, and any of them can exist in more patients than we think.
I hope so.
Comment? Βασίλη.
Μικρόφωνο όμως, έτσι, μικρόφωνο. Είσαι στη λάθος θέση, Βασίλη, στη λάθος θέση.
Are all these procedures in US below 65 years old covered by the Medicare or by insurance?
Yeah, Medicare doesn't exist in there, but commercial insurance exists, and I'm sure they're covered. The majority are covered.
Because
I'm sure some people can pay out of pocket, but most people are covered. Covered, yes.
Just a comment.
Yeah.
That heart teams, I think, should incorporate heart failure specialists. This is our practice as well, because they can offer their expertise before TAVR and especially after TAVR, because sometimes TAVR is just the beginning of the heart failure management. Just that.
I know Samatis wasn't here yesterday. We had discussion about that, and we said that, I'd said at least, that a new subspecialty of heart failure is emerging, and it is a heart failure related with significant valve disease. That we can say, okay, whatever, that's well known. I don't think it is. Most people were trained in heart failure at the era of IV drips, of inotropes, ICU, heart transplant, LVAD. That was their interest and their training. And then, of course, some people have valve disease, and they were discussing with the surgeons bridge to transplant versus maybe multivalvular disease. And that's it. So nobody was really trained in having multivalvular disease and maybe fixing one of those valves. And what happens with that? And is it moderate or is it moderate to severe? Should we do the aortic first, the mitral? Is it worth it? And now all these possibilities all of a sudden exist, and all of them can also be bridged to LVAD or bridged to transplant or just stand alone. I can tell you there is some people, many people perhaps in heart failure, that not only feel they don't, I don't know, they're not that equipped about it, but also maybe they don't like that. Maybe they like the transplant. So I think the new generation that see more of these things, they're going to be a little bit more acquainted with these types of things.
Thank you, George.
Yeah.
So, Arik, it was an amazing talk, but now we have an equally amazing talk coming up, and it's from Roxana Mehran. It's on new and future pharmacological therapies in cardiac